Okay, so I have, it's a great pleasure and an honor for me to attempt to put 50 years into perspective, which is a challenge because I've been doing it for 37 years and many days. It seems like it would take another 37 to get to where I want to be. So this is a historical summary and a very brief treatment of current and future problems with a focus on career development, which I think in many ways has actually become more difficult with the passage of time. The legacy from the viewpoint of the Acetabulum, you've seen the book, but unless you've read this article, I think this is a unique article within orthopedic literature. This is the JBJS American edition, 1964, which essentially gives us 98% of what we needed to know about treatment of pelvis and acetabulum. The next iteration was in 65 when the adaptation of the linguinal was universal, but at this point, virtually everything was there. And so what did he give us? He had an understanding of the osteology of the innominate bone, which was unique. That formed the basis of his understanding of radiology. He gave us a clinically useful classification system. The Kocher-Langenbeck had been already developed by Judet and Lagrange, but he developed the iliolinguinal and then took the Smith-Peterson into the extended iliofemoral. He pioneered all the reduction techniques. Every clamp that you've ever seen on this planet was envisioned by him and tried and was always laying on the back table. He was the supreme educator. This course has a direct lineage going back to the first course in 1984. He was extraordinarily gracious, non-judgmental, and his relationship with Judet is, I think, emblematic of what we would all love to have in our career. And that's a mentor who encourages us and thrives and is not threatened by our success. And certainly an example of that we can see in the results, which the two large series from his own and then Joel Matta, who can basically trace his lineage directly back, as we all can, to Emil's teachings. So one person largely responsible for virtually an entire field, unique in my experience. What's come since then? Well, we have certainly some augmented imaging capabilities. That includes both pre and intraoperative assessments. Surgical approaches have continued to evolve, and that includes posterior lateral approaches with a trochanteric flip, the anterior intrapelvic, and then a variety of other retroperitoneal anterior approaches, pararectus and others. The other thing that's happened is that I think 10 to 15 years ago, we used to debate whether there was ever an indication for total hip arthroplasty. And with the changing in demographics, that's been, I think, a sea change, and our ability to adapt with that is actually very critical. I've also listed navigation. I think that I've been looking at navigation in this field for 30 years and doesn't seem to have ever come to clinical fruition. And then for the acetabulum, I see a vanishingly small role for closed reduction and in situ percutaneous fixation. The challenges are these, and that is the results have plateaued. The best results are still those portrayed and documented in Lechonel and Matta series. We've already seen the changing epidemiology, with the skewing toward older patients, which in virtually every series have a poorer outcome than their younger cohort. And then the most difficult of all these issues is the workforce health system consideration complex. So I think in Europe and North America, we have in many ways created a delusional effect by training many trauma surgeons. And so that virtually every level 1 and level 2 center in the United States And approximately the equivalent in Europe has somebody who feels they are capable of managing these injuries. And if you add to that the barriers to referral, if you've been hired by an institution that expects you to do these injuries, then referral is an admission of defeat and will routinely bring down the administration on your back because of considerations about financial reimbursement, et cetera. And then I think we're all laboring within the issues of resource restraints, but I don't see any future where that's going to let up. I mean, we've seen the world economies devastated by the current crisis, but healthcare economics is a daunting challenge going forward. On the pelvic ring side, the distribution of contributions is much broader. We have the classifications brought forward by Pennell and Tile, and then further modified by Young and Burgess, and Letournel himself, based on mechanism, considerations of stability and anatomic site, as well as associated injuries. Open reduction was largely pioneered, although not much published, by Letournel, followed by Joel Matta, Sven Olerud, and many others. It included both anterior and posterior approaches to the pelvic ring. The next, I think, advent was that of the pushing the envelope for closed reduction and in situ percutaneous fixation. I think Joel would probably not want to be mentioned here, but certainly his initial imaging techniques were those that formed the basis for further developments by Chip Rout and others. And we've obviously enhanced our imaging protocols many times over the ensuing 20 plus years. And there probably is some role of navigation, although most of that, I think, the navigation is intracranial. The other things that have impacted pelvic ring injuries is early field or ER stabilization. I think this has been a huge boon to our outcomes. And certainly we have improved care of the polytraumatized patient, beginning with use of blood management, blood product management, ventilator management, on and on and on. So we have much better colleagues from that viewpoint. The challenges to the pelvic ring are that as we've increased the number of patients that are managed with closed reductions and internal fixation, we've had fewer and fewer opportunities to work on our open reduction skills. And since we're human, we like to do things that we feel most comfortable with. So if we do open reductions infrequently, then we frequently reach a point of diminishing returns. We also have to deal with the changing epidemiologies you already seen earlier with older patients, an entirely different set of clinical problems, and then all the same issues that we talked about as far as the acetabulum is concerned. I have a somewhat jaundiced view of the world literature. I can probably find only 50 articles in my career that have been impactful in terms of a long-term perspective, which is about 1 to 1.5 a year. This is just an example of things we'll see in recent literature, which is this unusual frame to manage a patient with a posterior column, posterior wall fracture with this complex external fixator, which you can imagine the downstream problems associated with this, even if it's not used for definitive management, but as far as temporization. We are great believers in the power of technology. So we have this patient with a transverse posterior wall. This is not a widely known journal, but there are so many journals and so many articles that if you're bored some night, sit down on Ovid or PubMed and do a literature search, and you'll be astounded by the articles that will come up. So the solution for this was not necessarily understanding the fracture pattern perfectly and creating a surgical plan which included a perfectly executed surgical approach. It's a 3D printed composite plate which takes 2 plates and a spring plate as a single construct printed in the lab and brought to the OR, notwithstanding the fact that the cranial portion of this plate is probably putting the superior gluteal neurovascular bundle at some risk. So if you're going to spend time on your career, be very careful how you use the world literature. Solutions, I don't think that we can envision a time in the near future or even intermediate term where technology is going to revolutionize what we do. We've been talking about bone glues and endoscopic surgery and robotic surgery for at least 2 decades. And in fact, our day-to-day practice has changed relatively little, and it's based on our ability to exploit our legacies. This is maybe, in some people's estimation, mundane, but if we can come up with an accurate diagnosis and a thorough preoperative plan, as we've seen from today's cases, and then manage a soft tissue friendly surgical approach to acetabular fractures and for a certain number of pelvic ring injuries, then we're going to be at a position where then if we understand the type of reduction techniques we need for a given injury and the implant placement and function, then we will have all the tools that we need. And I think we have been essentially forced to follow considerations of other anatomic sites where we now see anatomic plates for virtually every condition. And there's been a tendency to think that we can have a single-use, preoperatively generated CAD/CAM plate for each injury pattern. And I think the problem with that is that it leads us away from understanding what plate function is and where the plate should go, as well as the understanding of how we convert from clamps to screws and plate function. This is a German article from the 80s, which I think is just an early example of the correlation between the percentage of good outcomes on the left and the number of operations per year. I think this is exceedingly optimistic, so that we see if you can do 10 cases a year, then already you're in the 70%. And these are short-term follow-ups. And frequently our failures are not nearly as egregious as the one on the right, but the more subtle ones are equally damning to the patient over the long haul. So the question is, since dilution is a problem for many of us, how do we deal with this? And so then we have to look at strategies to overcome training deficits. So even if we're well trained, if we've had the benefit of good training through residency and fellowship, but we have a low volume practice, which is a reality many places, then what do we do? Because 100 cases over 2 years is far different than 100 cases over 10 years, in which case you may never reach clinical competency for a given injury pattern. And this has become much more difficult with the passage of time. When I was in training, if I wanted to go visit Eric or Joel or go to Paris, I could just scrub in and operate with any of my friends. And I would do that. I would take time away from my practice. And it was facilitated by a collegial relationship, which has now been made virtually impossible by medical staff hierarchies. It can still be done, but it requires licensure and a number of other issues. If that doesn't work, then establish a relationship to refer and assist if possible. So if you have a regional trauma center with a good resource, develop the relationship with that person or persons and figure out a way to go there and operate with them. That kind of experience can be invaluable. Many fellowships. Develop your friendships and your contacts from around the world. And this has also become much more difficult because of our medical staff bylaws, but it can still be done. Frequently it takes as much as a year in planning. CME should be generally cadaver-based because that's our simulation. And if it's not just CME, a lot of the major cities now have proprietary cadaver facilities which can be exploited. You use their implants, or somebody uses their implants in your hospital, the quid pro quo is to go there and use their facilities as a practice, particularly if you haven't done an approach in several months to a year. Go there first. Online resources are highly variable. Review those with somebody you trust before you blindly follow them, because there's some really, really bad content available. And then develop a pathway for remote consultation. And now that we have Zoom up and running, or meetings or other software options, develop a relationship with somebody that you know and trust, and be able to go over difficult cases step by step. Simulation may ultimately become available. We are a profession that has adapted some aviation principles. One of the aviation principles which we don't have is that, which has been longstanding in the aviation industry, and that is that long-haul pilots, because of the duration of their flights, transatlantic, transpacific, would frequently never have enough landings and takeoffs in their schedule to maintain currency. And that, since that's where most of the accidents happen, in the first and last phases of flight, then you would have to go as a pilot on the line to a simulator to make up for your deficits in landings and takeoffs. And you'd have to do that every month or every other month. Someday we may be mandated to do this. Right now, the currently available simulation comes nowhere near reality, but I remain hopeful for that. Ultimately, this is a career which demands long-term self-critique and a commitment to skill enhancement. Despite all of those things, there are very few careers in orthopedics or any area of medicine which are more gratifying at the end. So with that, I will end with Emil's encouragement. He has given us so much, and he used to always end with bon courage or carry on. And with that, I want to thank you all for your participation and encourage you to pursue this as far as you can within your own individual careers. Thank you.